name is Amy Brown. I'm a physical therapist, and I've been a therapist for about 27 years now. I've been doing this for a long time. The last 10 years have been here with Stoughton Health. And during that time, I really have always had an interest in learning more things. That's led me down a path where I have done a lot of advanced training. I've got my orthopedic specialist. I've got a doctorate degree. I did vestibular certification, and more recently the lymphedema certification. But I always felt like I was missing something when trying to help people who've had like chronic pain conditions. So I started to try to look more into the science of pain, and I'm kind of a science geek, so bear with me today, guys. I'm sorry. But the pain epidemic in the United States is basically, it's an epidemic that we're dealing with. According to the National Institutes of Health, pain management costs the United States between $261 billion and $300 billion in just direct medical care each year. And the total cost per year are about $560 billion to $600 billion. So it's costing our system a whole lot of money. And not just in money, though. We're having an opioid crisis where we're losing people due to opioid use. In 2021 alone, we had 80,000 people who died from pain medication overdoses. And 60% of all drug overdoses in the United States are due to opioid use. So it's not just expensive, it's also costing us lots of lives. The United States is only about 4% of our world's population, but we use 80% of all the pain medications in the whole world. And we use 99% of the hydrocodone in the whole world in our 4% of the population. So the United States doesn't have a workforce where we're doing more dangerous manual labor or anything like that could explain it. So we have to look more at like what we're doing to treat pain and how we can change our focus on this treatment. So that's kind of where this push has been coming from. I forgot to mention, if you have questions, I'm happy to answer them, but we'll just try to save them for the end for fluidity. But if you want to put them in the chat anytime you can, or if you want to save them for the end, that's fine. It doesn't matter to me. So how many people have actually really sat down with their doctors or other healthcare professionals and talked about pain? I'm going to bet it's not very many. But the first pain education really only started in the 1990s. So despite the education, medical schools and stuff generally only have a few hours worth of pain education. So a lot of doctors and other healthcare practitioners aren't very comfortable talking about pain because we don't learn a lot about it in our training. When we first learned about pain, we focused more on a biologic model. Basically, our tissue is damaged, and so then we treat that damaged tissue. And that works sometimes, and it works for our more acute pain, but it doesn't work at all when we start talking about persistent chronic pain. And so then we've had to change our focus and try to understand that. And so in the last 20 years, there's been a lot of research that's been done throughout the world to understand this. The Australians have been super helpful in this. They've had really great pain research. But now we're looking at a different model, and we call it the psychosocial model. And basically, this model is looking at the whole person and not just your shoulder or just your back. It's looking at the biology of our body, but also like how our brain influences that, how the lifestyle that we live in, the other social stresses we have, and how that all influences how we do or how we feel and stuff. And so we'll be talking about that today. It can sometimes be a little bit uncomfortable for people because we start talking about the brain and then people think we're saying pain is only in your head. And it's totally not true. I just want to put that out there right now. I'm not saying pain is in our head. It's just our brain is how we interpret pain. And so we can't ignore the brain in the process. Every response we get for pain comes from they're called nociceptive fibers, but fibers in our body. And those fibers sense things like tension or temperature or pressure, and they carry messages up to the brain. And they first go into what we call the limbic system, but it's kind of our body's emotion system. And it's where we decide, where we assign how we feel about what's coming in. If we're going to be stressed, if we're going to be content, if we're going to be angry or whatever, it goes that system first, and then it spreads out in our brain and it gets interpreted. And our brain then decides what we do about the response we're getting. So we can't ignore the brain in this process. We're going to first here assess a little bit of our knowledge about pain. There's a lot of questions here, and we're not going to have time to do all of them in our hour, but I'm going to prioritize a few of these, and we'll go over a couple of these answers or questions now, and then at the end, we'll go through the answers, and hopefully we'll have them all right then. So first, question number 1 is one we'll talk about. When part of our body is injured, special pain receptors convey pain messages to our brain. So you don't have to answer it anywhere except in your own head, but just think if you think it's true or false. And then number 2, pain only occurs when you're injured. So again, true or false on that one. And then number 3, the timing and intensity of pain matches the timing and number of signals in danger messages. And number 4, in chronic pain, the central nervous system becomes more sensitive to danger messages from tissues. And number 6, the body tells the brain when it's in pain. And then we're going to skip ahead to number 9. Chronic pain means an injury hasn't healed properly. So then I'm going to go to the next page here, and we're not going to do most of these because they get really sciencey. But we're number 11 is the brain decides when you'll experience pain. Again, true or false on that. And then number 12, worse injuries always result in worse pain. All right, so let's get started a little bit here. So first I wanted to say pain is a normal feeling. If we didn't have pain, we would die. There actually is a condition, it's called anhidrosis, and that is when people don't actually feel any pain. It's really dangerous, and the people who suffer from this condition actually die very young because they don't know to pull their foot out of the fire, or they don't know that something's painful, so they keep doing it, and then they inflict great bodily harm. So pain is really good. We don't always like it, but it's really important. And so early on, you can see this picture here with this man here. He has his foot in the fire, and you see this long cord or a nerve going from the foot all the way up to the brain. And this is initially how we thought that pain occurred. You have something painful happen, you have this nerve, that's a pain nerve, goes up to your brain and tells you have pain. And so then you pull your foot out of the fire. We've since found that's not really true. And the reason we discovered this isn't true is phantom limb syndrome. I'm sure you've probably heard of it, but if people like lose a limb, they often continue to have a lot of pain in that limb, even though they don't have it. So we know there's not a nerve there that's connecting from that limb up to the brain. So that's what kind of led us into trying to understand pain more, and so we could explain phantom limb. And so this is kind of a schematic of how a lot of people feel when they're actually having pain for a long time. You get stuck in this roundabout, and we all love roundabouts, right? But you're in this roundabout where you have pain, so then you start to lose hope and you get more fearful. So you're less active and you move less, you get deconditioned, you get more depression, and you do less and less and less. And then you just cycle in this pain. And we just want to get you out of this cycle so you can start to function more and do more activities and enjoy your life. This is really what it actually should look like, the roundabout here. Our goal is that people have an injury or some other stressor that gives us our pain experience here. And we want people to not go this way and get stuck. We want people to come this way. So part of this is what you guys are doing right now, is learning about pain and understanding pain more. So then we're not so fearful of pain, and then we can get moving and get doing things and doing what we need to do to confront the pain and get better. But sometimes it happens where we don't. We get here and then we don't really understand what's going on. And we come here and we get feedback from our neighbor who says, well, my mom had that and she never walked again. Or we see a doctor who does an x-ray and it shows you have all these bad things on your x-ray. And so then we start thinking, oh my gosh, how am I going to work? How am I going to pay my bills? And how am I going to take care of my kids, or whatever it is? and then you get very fearful about how you're going to get this done, and then you get more stress, and so you avoid activities, and then you get weaker and more disabled, and then it just again continues to cycle. So we want to stop this from happening here. There's been 4 pillars that have been found to be really helpful in the treatment of pain. And the first one's pain education, and that's what we're doing right now. We're at least starting on it. It's a huge, huge topic, and I can't cover it all in an hour by any means. But we will start with it today, and I just encourage you to continue to do that. Also setting goals for what you really want to accomplish in life. And then we'll talk about having action plans for that. Getting good sleep. And I can't emphasize enough how important sleep is. We'll talk about a little bit more, but sleep is really vital, not only for pain, but also for other life processes, cardiac function, all kinds of things. And then aerobic exercise has been shown to be really, really helpful for pain. But also some resisted exercises and isometrics have also been shown to be effective. So we'll start with education. So you may be wondering, does it help? And we'll talk about how it does help, and I'll show you the proof that it does help. The PNE here stands for Pain Neuroscience Education, and the NNT stands for Number Needed to Treat. So you'll see that in scientific research or health research. But basically, when we do an intervention, they'll report on the number needed to treat, or the number of people that they need to apply the treatment to for them to have a positive success. So for pain neuroscience education, if you treat 2 people, 1 out of those 2 are going to get better. So it doesn't sound that great, but if you're one of those 2 people, it is very good. Pain neuroscience education for pain, you need to treat 3 people to have 1 person get better. But then you start comparing it to medications like gabapentin, which is commonly used for chronic pain. You need to treat 6 people to have 1 person get the same benefit. And then same thing with antidepressants, you need to treat 7 people to get the same benefit. So it's about twice, the education is twice as good as taking these drugs, and there's no side effects. So it's been shown to be very helpful. And then, but often people then say, but I have degenerative disc disease, or I have arthritis, or whatever it is. And I just want to let you know that you can still get better. And we'll talk about that a little bit more, but many high-functioning people in the world have suffered from chronic persistent pain, and they lead very normal lives and have high function. So there's been lots of research, and I think this is really interesting studies, but they've studied people where they did MRIs on people who've had chronic back pain, or I'm sorry, these are MRIs where people had no back pain at all. And so they've taken like 100 people off the street, stuck them in an MRI machine, and then they looked to see what they found. This one particular one was done in 2005, but 25 to 50% of the people that they did this on that have no pain had all these awful sounding things. And these are like those scary words that doctors say, where then you think, oh my gosh, I'm never going to walk again. But all these people are having no pain and still have these scary sounding things. And then we've done the same studies on shoulders, and we found that, again, like if the overall prevalence of tears and rotator cuffs of all people is 35%. So 1/3 of the people out there have a rotator cuff tear, and again, don't even know it. And if you're over 70, 2 out of 3 people have rotator cuff tears and don't even know it. So the numbers are really high, and just because you have a rotator cuff tear doesn't mean you're going to have shoulder pain. And even people who've had these rotator cuff repairs, 90% of them still have abnormal signaling after the surgery and after they've recovered and done well. So, and then same thing with MRIs on knees. So they've done MRIs on knees, and 15% of all MRIs done on healthy people show degenerative meniscus, and only a 50% correlation between the percentage of arthritis people have and the amount of knee pain. So that's kind of flipping a coin there. And then this one's really interesting to me, but of all the college basketball players they've done MRIs on, and these college basketball players have no knee pain, but 35% of them show significant MRI abnormalities, and they're playing at really high levels. So again, just because it shows up on imaging doesn't mean it has to influence your life. So injury can occur. I'm just going to hide this because I can't see. I'm sorry. Injury can occur and result in no pain. Have you ever noticed a bruise or blood and didn't know how it happened? There obviously was an injury, and what we'll call it after today is called nociception, but there's still no pain. And there's a couple reasons. One is it could be just not enough nociceptive fibers that fired. You could have had past experiences that tell you it's going to be no big deal. You could have had other things going on that were more pressing or more distracting, like say you scratch or you stub your toe, but you also have like a dog that's chasing you and you got to get away from this dog, then you're not going to worry about your stubbed toe. And then we'll talk more about this, but there's internal pain modulation that we have, and that also can help us with controlling our pain levels. So one of the things, this is a really interesting report, but we're going to talk about the tale of two nails. So the first study, this is about, the study was reported in 1995, and the British Medical Journal reported on a 29-year-old construction worker who jumped off a structure onto a wooden plank, and a 7-inch nail pierced all the way through his boot, all the way to the other side. And so he looks down, he's got horrible pain. He's like yelling, carrying on. And his coworkers come running over, and they are showing anxiety in their face as well, because you can see this nail sticking out his boot. They take him off to the ER by ambulance, and the ER gives him a whole bunch of pain medications, and he's still in horrible pain. They finally are able to take the boot off, and they discovered a miracle. A nail went between his big toe and his second toe, didn't even touch his toes. Didn't leave a scratch, nothing. But this guy really did have pain and had no injury at all. And what really happened was, like, he had seen it and his brain sensed danger. And then his coworkers came over and they were giving him feedback that was like, oh my gosh, kind of feedback. And then the healthcare practitioners are also given that same feedback, and his brain interprets it and says, I need to protect you and keep you safe, so I'm going to give you pain. And then we have the exact opposite tale. So this one, there's another construction worker, and he was using a nail gun, and it went off unexpectedly and discharged. But he thought the nail went off to the side, but the nail gun actually hit him in the jaw. But so he had a little toothache and a little bruise under his jaw, but otherwise he thought he was fine. But 6 days later, he kind of was still having some tooth pain. So he went to the dentist, and they x-rayed him, and this is what they found: this nail going right through the middle of his skull, and it's actually up into his brain cavity here. And this man, really, all he had was a mild toothache. So despite the fact that he was in really quite grave danger, his brain they gave him the opposite cues. He told him he was fine when he really wasn't. So it just shows us how powerful our brain is in interpreting what we're going through. So then this is a schematic here of what happens with tissue healing. So we have an injury here, and we have this response where our tissues come up and heal here. And then over the next several weeks to months, the tissues heal. And normally our pain goes away then. But sometimes, and this would be like an acute pain here. So we'll separate acute and chronic as we go. And this is the pain response. So normally you get hurt and it hurts, and that's normal. But this should then kind of continue to taper down with injury and go away. But occasionally with chronic pain, this pain response keeps going, and sometimes it even increases for months or years after this tissue injury and the tissue healing. And this is what we're going to be talking about today and working on trying to fix for people, or help them fix. So this is an MRI of somebody. It's called a functional MRI of somebody who had back pain. And this first row here that you see shows this person resting quite comfortably in the MRI machine. And they're just laying there, whatever, listening to nice music or whatever. And then here they ask the person with the back pain to do a painful exercise. And you can see here how much of the brain actually lights up. So we don't just have one little center of our brain that's lit up. It's like the entire brain. You can see it everywhere. And if you've had pain very much and you find it hard to concentrate or function, this is why, because all your brain is so busy thinking about your pain. But then what they did here is they took this person out of the MRI machine and they gave them about a 20-minute education session on pain. And then they put them back in the MRI machine and had them do that exact same painful exercise. And this is what the brain did then. It calmed way down. There's a lot less activity. And the person felt better too. They had less pain doing the exact same exercise. And all they did was talk about pain. So pain education can be really helpful too. So this is an alarm system. And if you think of your pain as an alarm system, our brain's goal is to just protect us and keep us safe and keep us alive. That's our brain's goal for everything. So if our brain is always working and it's always telling us whether, or it's always firing basically. And if we're functioning normally and haven't had chronic pain, it just fires down here at this level. We don't want it to be nothing, because if something happens, we don't want the system to be turned off. We want to know about it, right? So we want it to be down here. But when we've had pain for a long time, we get this extra sensitive system. So it's still firing all the time, but it's firing way up here. And so this person with this extra sensitive nervous system here doesn't have much activity before they're in the zone where they're into a painful firing level here. So if you do it like this person does an activity that really only increases the feedback about this much, they have no pain. But if this person with the extra sensitive nervous system does the same intensity activity, it's going to give them pain. So our goal is to dial this down and like turn down your volume basically to help bring this down so it looks more like this. When a nervous system is hypersensitive, it can respond to things like say walking across the room might be painful when it shouldn't be. And if you think of like a home alarm system, you don't want it off because then people can break in. You want it to set just right. And if it's set too tight or too sensitive here, like a leaf blowing by your window could set off the alarm and then you're not going to respond well to it. So we just want to get you back down here to that level. And we'll talk about ways you can control that volume knob to help bring your pain levels back into control. So another pillar besides education was exercise. And you might be asking, why don't I get better with activity? Because a lot of people have tried to exercise and they don't get better with exercise. And the answer is you may be overdoing it or you may be underdoing it. And so we have to find just the right level for you. This slide here talks about our endogenous pain medication. Basically, our brain produces it's called endorphins, and that stands for endogenous or internal, and morphine. So our body's own ability to produce our own pain medication. And normally we do something like stub our toe, and our brain will your toe will send a message up to the brain that says, I just stubbed my toe. And then your brain will say, oh, that probably hurts. I'm going to secrete this endogenous morphine to help you with your pain. So you stub your toe, it hurts for a few minutes, and then you feel better. But in somebody who's had pain for a long time, this system kind of starts to dry up. And that's because your brain has said, uh-oh, there's pain, there's pain, there's pain, there's pain. And so I better stay on high alert and be ready for more pain. So I don't want to damper it with these natural pain medications that I could produce. So it turns the system off. So the people who need these pain medications the most, their body isn't producing it for them. So we want to turn the system on. You might hear me call it dry brain and wet brain later, but we want to have a wet brain or a brain that can produce these endorphins for us to help us with our pain medication or our pain control. So this is a schematic of what happens if we exercise too aggressively. So if you exercise too aggressively, you're going to have these big spikes in pain, and then you're not going to want to do much. So you're going to do nothing. You're going to come way down to here, and then you're going to try to do something again. You're going to have this big spike in pain. And this isn't effective at all. First of all, you're uncomfortable a lot, but also the brain then continues to learn to associate activity or exercise with pain, and it makes you very fearful of moving. So we don't want to exercise this way, but we also don't want to exercise this way. So this is what if you don't do enough, where you're never getting close to the system and you're never retraining your body. It doesn't teach your brain anything, and it also helps lead to deconditioning and weakness. So then you have more troubles too. So we don't want to work out here either, but this is where we want to exercise. where we're just basically working to the point where we just start to feel a little stress or strain or just mild discomfort, and kind of like tease the system, where you're retraining the system, and then the body will like start to adapt, and that activity that was used to be painful will become less and less painful, and you'll be able to do more and more activity. Oops, I'm sorry, I went the wrong way. So it should look like this, where we're working out at this level and training the system a little bit, just stressing it a bit close to that level. And then when we can tolerate this level, we bump it up just to the next step and then work there, and then to the next step and work there. And that's our ultimate goal, is just to tease the system a little bit and pace ourselves so we only have mild discomfort, but we train our brain to not be afraid of movement or pain. So aerobic exercise has been shown to have the most influence for reducing our pain, but we also can benefit from strengthening isometrics. Exercise has been shown to improve our physical function, our mood, and reduce health problems, including metabolic conditions like diabetes and stuff, bone diseases like osteoporosis, and neurodegenerative diseases like Alzheimer's. Long-term exercise training has been shown to provide pain relief across many different chronic pain conditions, including fibromyalgia, arthritis, back pain, neck pain, and neuropathic pain. And the Arthritis Foundation, that's the first thing they listed for activities that you should do is exercise if you have arthritis. Our goal ultimately is to work up to 30 minutes of exercise 5 days a week with a moderate intensity. But we want you to start slower than that. We want to set realistic goals. So if you haven't been doing much activity, you don't want to start that aggressively, or you'll be back on that yo-yo that we talked about. So we want to start slower and increase as able. It might only be a few minutes at a time, and then increasing that. But the key is to choose an exercise that you like to do. If you hate swimming, don't go swimming. If you hate, I don't know, biking, don't bike. Choose an exercise you want to do. And if you can, find a friend or family member, somebody to exercise with, because it's always more fun. So this here, we'll talk a little bit about how you set up an exercise program. So you can monitor your heart rate. The ultimate goal is 60 to 80% of your maximal heart rate. So if you find your pulse by your thumb here, you just rest 2 fingers on it, not your thumb, but 2 other fingers, and you just feel for your pulse there. That's one way to check it. You can also check it on your carotids, right on the side of your neck here. And you should feel, or you don't want to cross over because you tend to clamp it too much there, so you stay on the same side. And basically what you do is you count the number of beats that you feel in 10 seconds, and then you can multiply it by 6. And that will give you your resting heart rate. If you don't want to go through and calculate your maximal heart rate and the 60 to 80%, if you just aim for at least 100 to 105, it's a good starting point. But if you want to like get more specific, basically to figure out your maximal heart rate, you take 220 and subtract your age from that. And then you take that number you get and multiply it by 0.6. And that would be the lower range that you want to work at. And then you'd multiply that the 220 minus your age by 0.8. And that's kind of the upper range to start at. And then choose your exercise. You want to, again, make it something that first of all is accessible. So even if you love swimming, but there's no pool anywhere near, don't pick swimming. But like say walking is always an easy one because it's very functional and we don't need any fancy equipment or anything like that. You just need shoes. But pick what exercise you want to do. And then you want to choose the days a week you're going to do it. Like I said, we suggest 5 days a week ultimately, but you may only start with 2 days or 3 days and then bump that up. But schedule rest days in between. So if you're doing 5 days, maybe do 2 days of exercise, take a day off, do 3 days exercise, take a day off. So you get a rest break in there. So it's really important to actually pick what days you're going to do it. So otherwise it's too easy to go, oh, I'll do it tomorrow. I'll do it tomorrow. I'll do it tomorrow. Because that's what we all do. And same thing with picking a time of day that you're going to exercise. If you don't schedule something, you're more likely to put it off and not do it. So it's really great to schedule it too. And then let other people know your plan. It helps make us more accountable. and they may want to join you too. And then, like I said, start smaller. It may only be every or maybe only 2 or 3 days, and it might only be 5 minutes at first or 3 minutes at first if you haven't done hardly anything. But then keep slowly bumping it up and pacing it like that one graph showed. And another trick that sometimes helps is actually logging your progress. You can write down how much you did, and then track your progress there. The key is to stay really positive with this. There's research that shows if we're negative with ourselves and we don't give ourselves credit for what we've done, we actually increase a stress hormone called cortisol. And we'll talk more about cortisol in the future, but it can actually lead to more stress and more pain. So be positive with yourself and give yourself credit for the good stuff that you do. And then we'll talk about sleep. This is where we'll talk more about cortisol too, but oops, I'm sorry. As we sleep, we cycle between light sleep, slow wave sleep, and rapid eye motions. So in order to feel well rested, we need a balance of all 3 stages. When we have chronic pain, sleep can be affected. Either pain may lead to reduced sleep, or reduced sleep can lead to more pain. Or it might be some combination of both, and we can't really tell which is which. But sleep is controlled by a balance of a natural substance called melatonin that helps us go to sleep, and cortisol, which is another natural hormone we have that helps us wake up. And so if they're out of balance, our sleep cycles are messed up. So cortisol is the body's primary stress hormone. It helps regulate our blood pressure, balance our blood sugar. It also influences inflammation. So I don't know if you've ever felt more stressed and have more pain. That's why. It helps regulate our energy levels, and it also contributes to cardiac function. So when our cortisol is off balance, we can have all kinds of things like elevated blood pressure, more diabetic insulin control issues, more pain, and also just like more heart conditions that we have to deal with. So we want to control our cortisol as well. The system actually is regulated by 3 different parts of our brain called the hypothalamus, the pituitary, and the adrenal glands. And so we need all 3 of those systems in balance. So here's some tips that can help us with sleep. I'm just gonna move this again so I can see this better. Sorry, I might have went too far. There we go. I'm sorry. Below is a list of strategies to help us with sleep. Number 1, setting a regular bedtime. The ideal time is always before 11. The research has shown if you stay up past 11, even if you get 8 hours of sleep, you don't cycle through the REM cycle as well. And then you're not getting a balance of those 3 cycles. You want to have your house quiet, turn off your computer and TV. You can have white noise, but not those types of noises. Reduce your fluid intake in the evening. Again, we just don't want to have to get up and go to the bathroom as much. And then reducing your alcoholic beverage in the late evening is also important. When we drink alcohol, it can make us fall asleep better, but we don't cycle through our 3 cycles of sleep well. And so we don't have good sleep. You want to have a dark and cool bedroom. The research shows about 65 to 67 is ideal temperatures for sleep. Get your kids and your pets out of your bed. They tend to wake you up and disturb your sleep. If you're one of those people who have a hard time with like just shutting your brain down because your brain is always telling you, I gotta do this, I gotta do this, I gotta do this. You can put a notepad by your bed and write down things before you go to bed so you don't forget them, and then you won't be thinking about like, oh, I won't remember that, and then you'll be afraid to fall asleep because you'll forget it. And kind of along the same idea here, it's skipping ahead, but don't check your emails or your messages right before bed either, because then we start thinking of all these other things we need to do again instead of going to sleep. You can relax, meditate, or read a book before bed. This stay in bed is a little controversial. There's 2 different, half the people think you should stay in bed and half think you should get up out of bed if you can't sleep. But the people who think you should get out of bed basically suggest your brain is going to get frustrated and you're going to associate staying in bed with frustration. So if that's you, then by all means get out of bed. That's fine. But you don't want to like turn on a TV or go on your phone or use that kind of light source. So you want to get up and do an activity where you're in dim lighting, maybe you read a book or something where you're not having the blue lights from devices. And then try to stay on a regular schedule too. When COVID happened, we were laid off for 10 weeks. And the first week or two, I was like, I'm sleeping in, yay. And it messed my sleep up so much. And so now even on weekends and stuff, I still set up alarm and I get up within an hour of my normal time, and just try to stay on cycle. And I sleep so much better and I'm so much more rested. So, and then eliminating naps. If we nap much, it really messes up our sleep schedules at night. But if you do have to take a nap, because sometimes we do, but if you do need a nap, try to limit it to only 20 minutes. So set an alarm so you're not sleeping for hours because you won't sleep well at night. And then avoiding caffeine in the late afternoon or evening, and then exercise. Again, exercise does help reduce our cortisol. And if our cortisol is better or is reduced, our melatonin can be more effective and we'll sleep better. Deep breathing also can help us not only sleep better, but it can also help us reduce our cortisol as well. So you can just lay in a supported position. It's helpful and when you're not sure how to deep breathe to rest one hand on your upper chest here and then the other down on your belly. And when you take your deep breath in through your nose, you should feel your ribs and your belly expand, not your upper chest. Your upper chest should be pretty still. Unfortunately, when we have pain, we do all of our breathing up here, and then we don't get that deep breath and the cortisol release. So slowly breathe in through your nose, expanding your tummy against your hand. And then when you let it out, breathe out through your mouth and let your tummy muscles go all the way in. It's recommended to start laying down because it's just more relaxing. But as you get better, it's good to do it in another position. So if you're doing something where you have to be standing or sitting, you're able to do these cleansing deep breaths to help you relax. And then goal setting. We like to focus on what we call SMART goals. And SMART goals should be specific, measurable, achievable, relevant, and time-bound. So what that means is specific means it's geared towards what you want to be able to do. So if you want to be able to do something that requires you to walk, I would set your goal based on that walking. You want it to be measurable, so you can see if you're obtaining your goal. And again, it should be achievable. So if you've never hardly gotten off the couch, don't pick a goal to win the Boston Marathon because it's just not achievable. You want it to be relevant again, and then you want it to be time bound. So you may want to set a big goal and then set smaller goals. So like say you want to take your family on this big trip to Disneyland. You'll need to know that you have to stand, you have to be able to walk, those types of things. So you may want to set a specific goal for your standing tolerance, or you might want to set a specific goal for your walking tolerance. But then like say you're going to have to be able to walk 30 minutes to get from this ride to that ride, or from the parking ramp or parking lot into the park. So your ultimate long-term goal will be I can walk 30 minutes straight. And again, achievable. And it's relevant to what you want to be able to do. And then the time bound would be I want to be able to walk 30 minutes by February when I'm going to Disney World. But then you might want to have some smaller short-term goals in there that say like, okay, I know I can't walk 30 minutes straight right now. I can probably walk 10 minutes straight. So maybe set your goal for, I want to be able to walk 15 minutes straight. And then within 1 month or whatever it is. And then you want to have an action plan. How are you going to achieve that? So, well, if you want to walk more, you're going to set a plan where you're going to slowly increase your time for your walking. And then again, track your progress towards those goals. And if you don't meet your goals, or your goal, you decide, oh, I set my goal way too hard, change it. That's fine. But then just again, stay positive about the successes you are making. All right, so we're back to this. Everybody hanging in okay? So again, number 1 was one of the ones we did. What part of your brain, or when a part of your brain body is injured, specific pain receptors convey the pain message to your brain. And that's false. And it's false because, again, we don't have pain nerves. We have those nociceptive fibers that sense things like pressure or temperature or stretch or heat or whatever. They send the message up to the brain, and then the brain interprets whether it's pain or not. Pain only occurs when you're injured. And again, that's false. If you think of our Our guy who had the nail go through his boot, he didn't have an injury, but he obviously had a lot of pain. The timing and intensity of pain matches the timing and number of signals and danger messages. This one's a little bit more complicated, but it's false. And it's false because we have those other things like the endogenous morphine that our brain will release that can change the intensity of the pain. And we can have other factors like distractions and stuff that can influence that. Nerves have to connect a body part to the brain in order for that part to be in the brain. And again, that's false if we think of our phantom limb syndrome. And then number 5, in chronic pain, the central nervous system becomes more sensitive to danger message from tissues. And again, that's true because we've got the wet brain versus dry brain. So we aren't producing our natural endorphins. And so we have more pain and we're more sensitive. The body tells the brain when it's in pain, and that's false. It's the opposite. The brain tells the body when it's in pain. And then I think we skipped down to number 9. Chronic pain means a tissue hasn't healed properly, and that's false. Most of the time, our tissues heal on their own quite well. Our body's great at healing, and usually within a few months. And then I'm just going to skip to the next slide here. Number 11. The brain decides when you'll experience pain, and that's true. And then worse injuries always result in worse pain, and that's false. If you've ever heard of let's say a farmer who's been out working in the field and he sticks his arm in the intake and cuts his arm off, and he looks down and goes, shoot, and gets in his truck and drives himself to the hospital. He's not out screaming in pain because he's had so much of that endorphin release and stuff. So it can be very helpful and powerful in avoiding that. All right, so here's some take-home ideas, and then we can spend some time talking about this. But pain is not all in your head. However, it's at least part in your brain, and our brain is what interprets the pain. Pain serves as your body's warning system. It motivates you to take actions to stay safe. However, because pain is just an estimate, it's not accurate all the time. So hurt isn't always the same as harm. Cognitive, emotional, and contextual factors always inform pain processing. Specifically credible evidence that your body's in danger will give you more pain. So if you feel like you're in pain, you're gonna have more pain. But if you feel like you're safe and you're in a safe environment, your pain isn't going to be as intense. So we have the ability to change our thoughts and perceptions and emotions and how we feel, and we can reduce our pain through that. So you have control over your pain, and a lot more than you realize anyway. Treating chronic pain is with only pain pills and procedures is insufficient. That's just treating the tissue, and it has so many other factors. The limited treatment approach is one of the primary causes of the opioid epidemic that we have and is ineffective for long-term care. So you're in control. So move, get some good sleep, set realistic goals, and modify them as needed, and continue to learn more about pain in your body. So these are some places that I think are really great resources for more information. If you're more interested in sleep, Dr. Matthew Walker is a PhD researcher on sleep. He's really, really interesting and not too science geeky like me, but he's super interesting and has a lot of podcasts out there that are good. He really ties back how sleep is important to all different facets of our life. For pain research, Dr. Adrian Lowe has quite a few podcasts. He's a physical therapist. And basically he's from South Africa. South Africa. So he's got a really fun accent too. But he has spent most of his career studying pain and researching pain and educating people on pain. So he's very knowledgeable. And then Dr. Rachel Zoffness is actually a psychotherapist. And she had chronic pain when she was younger and was really frustrated with the healthcare system and the psychological system too, but how it all treated pain and didn't treat pain. And so she spent a lot of time with all the different pain researchers and learned a lot. And she's created this new pain management workbook that you can buy on Amazon for $20. And they have like a teen version and an adult version. And there's lots of helpful tips and things to work through on there too. There's also this app, it's called Curable. You may have seen commercials or heard about it, but it's a relatively new app. It does have a cost to it. And I don't know what it is a month, but there's a monthly fee. But it has lots of evidence-based approaches to treating pain, and it has you do surveys and stuff early on, so it gears the program towards you specifically. So it's really great. If you're really interested in this, if you let me know, I'll give you my information yet, but if you let me know, physical therapists have the ability to set you up for a 6-week trial for free. So I'd be happy to do that for anybody too. And then you can just search pain neuroscience and you'll find a bazillion things out there. Some of it's very sciencey, but there is other stuff that has been geared down to the general public and stuff too. So some great resources out there. And so these are some of the references I used. I'm gonna send the PowerPoint presentation here that I'm using to Kelly. So if you're interested, she can get it off to you through your emails and stuff. So then you could have all these slides here too. But there's different, some of these again are more sciencey, but there are some more indirect or more patient-friendly ones there. And then here's my contact information. So if you want to contact me, my email address is abrown@stoughtonhealth.com. And then my work phone number is 608-835-5373. I'm usually not sitting by a phone because I'm treating patients, but you are welcome to leave me a voicemail and I will get back to you when I get a chance to. So that's all I have. So at this point, I'd love to open this up to you guys and make this more about what you guys are interested in and questions you guys specifically have. Kelly, do we have any chat questions? I didn't look.
I don't see any in the chat.
Okay.
But I actually have a question.
Yes.
Can people make an appointment with you for this? Like you can get them on a protocol for pain management?
Yeah. So, we tend to we'll do a full regular assessment. Like, so if you're having just generalized pain, it'll be a very general eval. But, if you're having back pain, we do assess your tissues still. So we'll still look at your back, we look at your hips, your other tissues in the area and stuff, and we assess for like biologic things that we can change. But we also then gear your education into more how do you deal with your chronic pain, and specifically like more what your stressors might be or what you can do more specifically, and then gear your education sessions towards that too.
Great, thank you.
And if you have Medicare, you still have to have an order from a physician to have physical therapy. If you have a regular commercial insurance, you don't have to. So maybe our government will get on board and not require that yet. But as of now, you still have to have an order for physical therapy with Medicare.
Okay. Yeah, I have quartz and I was able to self-refer to OT. So yeah, people might want to take advantage of that. I see a couple things popped in the chat. Can you see them?
Yep, I can see them here. Yep, thank you. Okay. I think I can. Let's see. All right. You haven't mentioned anything about diet. Is there another, or isn't that another huge key in pain management? Yes, it is. There is a whole bunch of research out there, and I'm not a nutritionist, so I didn't focus a lot on that. And it actually isn't one of the pillars. But it is. There's certain foods that tend to increase our inflammatory response, and for some people more than others. So some people have a significant wheat intolerance or whatever, and that'll cause more inflammation in their body than somebody else too. So, so yes, that is true. And I guess if you do have dietary restrictions or anything like that, nutritionalists are great resources for that too. If you have diabetic issues, things like that too, if you're not managing your blood sugar levels and stuff, again, that's going to cause more of a pain response because you're getting those stress hormones or the cortisol to be affected too. So I'm a firm believer in moderation and balance in everything. And I agree the same thing in diet. I think if you're very restrictive in diet, you're going to crash the other way. Same thing, if you're incredibly intense in your exercise, you're going to crash. So it's finding that right balance for you. And if you find, some people have found that they'll like take away a lot of their foods and stuff, like the foods that have been known to be more inflammatory, like dairy or your wheats or whatever, they'll take those completely out of their diet and they'll see if it changes. And if you notice a change, then you know that yes, something you're eating is influencing you. And then what you can do if you've done that is the huge restricted diet is slowly add a few things in and then see if you respond. If you add in a food and then your pain levels go up and your inflammatory response goes up, then you can start to think, well, that food is probably more of a trigger for me, and then restrict that food specifically. So I hope that answered that. Again, I'm not a nutritionist, so I hate to speak too much out of turn, but ongoing shoulder impingement. Been to the doctor, had an x-ray and MRI. I assume it's osteoarthritis and rotator cuff. Best thing to do, specific exercises. Have been to PT pain, or is this the same one? Never goes away from the message above on shoulder impingement. Okay. Idea of sleeping positions. Okay. Yeah. So shoulder impingement, again, it tends to be because we have an imbalance where our deltoid is overpowering our rotator cuff, especially our rotators of our rotator cuff. And so here, I'm going to top of my hands here. So we've got the acromion, or the top bone of our shoulder, and then you've got your arm bone here. And if the deltoid is overpowering our rotator cuff, what happens when we raise our arm up is it comes up and it hits, and you pinch the tissue like this. And the goal of those rotator cuff muscles is to keep the ball down. So as we raise our arm up, it doesn't come up and pinch. We usually have pain right in the mid range because that's where we have the least space. And usually once we get above here, the ball tends to drop down. We get less pinching. So in true impingement, we have the most pain from about here to here, like that. So it is, yes, strengthening those rotator muscles and stuff. Sometimes people have like specific tissue where like the acromion, or this top bone that I talked about, the roof here, has different slopes. So we call this a type 1. It's nice and flat. Type 2 goes down a bit, and then 3 and 4. And so the more this bone points down, the more you're going to have impingement. And certain people, no matter what we do, no matter what they do, they can't overcome that. And they have to have that surgically cleaned off. And so sometimes the tissue is the main problem and that has to be fixed. So, I'm sure if you had your therapy before, the rotation exercises, so either rotating outward, I'm sorry, I'm trying to do this on a little screen, rotating outward with your resistance, or with your other hand pushing in and out like that. Controlling your shoulder blades, really important. And then maximizing the joint space right here. Those are the key things we do. Sleeping positions, most people don't tolerate laying on that side directly, and they'll have to lay on their back or the other side. But if the arm drops down like this, if you're laying on your back, there's a lot of stress on the front of your shoulder, and that tends to be painful. So sometimes people need a pillow to put, like, I'm going to try to stand up here for a second and not get too high, but they put a pillow kind of like here, so it's under their arm and like through here to kind of support their arm like this to help support it. If you're on your back and on your side, sometimes people have to put a pillow right here and then like have it like a hugger pillow kind of there. Because when our arm is tied up against our body, our rotator cuff twists a little bit, and it's kind of like if you think of a washcloth and you squeeze it like this, you're squeezing the blood out. And tissue doesn't like to not have good blood flow to it, and it tends to hurt in that case. So when we have our arm away from our body a little bit, the fibers aren't twisted like this, they're straight. You get better blood flow. So those are the key things with sleep, I guess.
Amy, I have another one.
Yes.
You mentioned fibromyalgia on one of the slides.
Mm-hmm.
I have a couple of friends that have that, and it isn't very specific. It's kind of all over, and it changes day to day. So since you don't have like the shoulder to address, how do you even start with someone that's in that position?
Yeah, it's you do a full assessment then of everywhere and see if there's any specific structures that are really tight or really weak. And then you would specifically gear towards those. But otherwise, it's usually about balancing the stressors in life. A lot of times if our stressors are really elevated, our pain levels are going to be really elevated. It's about starting an aerobic exercise program, making sure you have good sleep hygiene. a lot of times people who have fibromyalgia don't sleep well and they have a lot of like gut issues, or they tend to have like irritable bowel syndrome and stuff like that that go along with it. And stuff. So then you're also looking at dietary things, if that's the case too. But it's still the same 4 pillars. You're still like, you're starting to get some exercise, you're working on good sleep, you're understanding what fibromyalgia is. And again, not catastrophizing it, because sometimes at this point, when people get that diagnosis of fibromyalgia, they think their life is over, and it's not. And they feel like they don't have control. And so it's like learning that you have control again, and trying to figure out how you can control it so you turn the amplitude of that pain down. Does that answer the question?
Yes.
Okay. Any other questions before we sign out tonight? Like I said, I'll get this handouts to Kelly so she can forward it to you guys too. But you can feel free, if you want to, just like, if you have a specific question, you want to just drop me an email or whatever, that's fine too.
Great. Well, thank you, Amy. That was terrific.
Yeah, thank you everybody for coming.
All right.
Thank
Good
you.
night, everybody.